Good evening and welcome to our webinar. My name is Errol Williams and I'm one of 4 development managers working for Glaucoma UK. Our speaker this evening is Mr. Mike Smith, consultant ophthalmologist at the Royal Devon and Exeter NHS Foundation Trust, and his talk will be on communication and how to get the most out of your clinic visit. Right, my second slide, I'm just going to talk to you a little bit about exactly what we do. And we have 3 points that we look at carefully. And one is to create awareness of the condition via advertising and the use of social media to encourage people to visit their optician as early in life as possible and to repeat that exercise every couple of years. Glaucoma has been described as the thief of sight because we wouldn't know that damage to your optic nerve was actually occurring without a visit to your local optician. The various tests they carry out will indicate the possibility that you have glaucoma and would refer you to your nearest hospital for a diagnosis. But secondly, we have the tools to help and educate you about glaucoma. We supply booklets free of charge. We have an interactive website and we use social media. Recently, we took on board Health Unlocked, which allows people to ask questions about their condition and gives us and others the opportunity to respond. We also have a helpline available to you between 9:30 and 5 p.m. 5 days a week. We support research and we allocate £200,000 per annum for various projects. We have a professor of glaucoma and allied studies who in 5 years acquired almost £12 million for glaucoma research. So those are the 3 main tasks that we try and achieve. So without more ado, I'll pass you on to Mike.
Hi, good evening, everyone. Yes, I'm Michael Smith, glaucoma consultant in Exeter, and thanks for joining us this evening, and thanks to Joanne and Errol for inviting me. So I've got some slides which maybe last sort of 20 minutes, half an hour, and after that, any questions I can answer to the best of my ability. I've spoken to our local support group on a number of occasions and always enjoyed it, and although this is an unusual format, I hope you will find it useful. Okay, so I'm going to talk about communication in glaucoma clinic, how to get the most out of your appointment. So why is this important? Well, it's important, I think, because clinic visits are a very precious resource, and that's true now more than ever. On the right of the screen, this was a statement released by the Royal College of Ophthalmologists and the College of Optometrists, and urging the government to do something about the delays in hospital eye care. And you may notice the date on it is from February of this year. So this was before COVID, and obviously things have got a lot worse since then. So we must use this time well, and in my view, good communication is key to this. So these are some benefits of good patient-clinician communication. I'm not going through all of these, but just to highlight a few. So increased patient autonomy and improving patient ownership of their own healthcare. I think this is good in itself. It's your eyes, after all, not mine. But also we know from studies in other areas of medicine that people who are more involved in their own healthcare are better at taking their treatment. And we do know in glaucoma that good adherence to treatment is associated with good outcomes, i.e. less loss of vision. Higher patient satisfaction has been shown, and also possibly reduced clinician burnout. You know, essentially, with good communication, patients are happy and the staff are happy. What's the barriers to communication? Well, I think mainly it's really just that we, as in the clinicians and also the patients attending glaucoma clinics, are all humans. So some personalities get on with others, get on more than others. We all have good days and bad days. You know, ideally life stresses and work stresses wouldn't feed into this, but you know, in reality, they can do. Also, a significant portion of people with glaucoma are of an age where memory can be an issue. And this is quite a hard thing for us to assess in the short appointment time that we have in glaucoma clinic. And then there's the elephant in the room, which is time. And anybody who's been to glaucoma clinic knows that time tends to be short. So the clinic visits, what are the aims of the clinician? Well, these are generally the things that we're looking for. Are the eye pressures okay? Is the glaucoma damage getting any worse? Is this person at risk of visual loss? Is the person taking their eye drops? Do we need to change the treatment? And then how about the timing of the next visit? And what about the person who's attending clinic? Well, you know, again, this doesn't cover everything, but generally speaking, what they want to know is my glaucoma getting worse? Is my current treatment the right one? Am I going to lose my, depending on the severity of the glaucoma, am I going to lose my vision? Am I going to lose my driving license? What about reading, TV, and so on? And finally, when will my next appointment be? So you can see the aims are actually quite similar between the patient and the clinician. So I think it can be useful to understand what the aim of glaucoma treatment is. I mean, this sounds quite simple, but you know, what we're really trying to do here now, glaucoma is generally not curable. So we're trying to ensure the individual keeps the amount of vision they need for a good quality of life for as long as they need it. So, you know, that sounds sort of straightforward. However, glaucoma gets worse at different rates in different people and also sometimes in the same person at different times. When we refer to the vision that people need, that varies quite a bit between individuals and also can vary at different times in your life. It's pretty obvious to think, you know, the needs of a 50-year-old HGV driver may be different from the needs of most people attending glaucoma clinic. Life expectancy and age, well, really that's important simply because if somebody has glaucoma and it's getting worse slowly, then that's much more likely to cause them problems if they're 40 than if they're 95. And then there's the issue of the tests that we use to decide how much worse the glaucoma is getting and how much of a threat it is to their vision are far from perfect. And I'll touch on that a bit more. And all of this must be balanced against the side effects of treatment. So when you go to your appointment, what is the clinician looking at? Well, a number of things, but these are the main things we're looking for. So the eye pressures, also known as the intraocular pressures, or IOP for short. And we're looking for evidence that glaucoma damage is getting worse. And for that, mainly we use the visual field or the peripheral vision test and the examination of the optic nerves. And that's a picture on the right there of an optic nerve. Now, this is how we measure the eye pressure. And I suspect all of you will have had this done. There are several ways of doing it, but this is the most commonly used method in glaucoma clinic. So in the top left, that's the instrument we use, the tonometer. And the top right, so the person has some drops in their eye, some anesthetic with some yellow fluorescein dye. The tonometer is brought towards the eye and very lightly touches it. When we're doing that, we're looking through the slit lamp, and on the bottom right there, what you can see is these two half circles. And on the left is a little dial that we're turning. And as you turn that, the circles move back and forward against each other. And the end point is when, as we see in the photograph there, when the inside edges are just touching. And then we read the pressure off of there. Although it says 2, 3 and 4 on it, that's actually 20, 30 and 40. And it works on the principle that the higher the pressure in the eye, the more the taurometer needs to push on the surface of the eye in order to create a certain indent. So when you're having your eye pressures measured in glaucoma clinic, that's what we're doing. Many of you have heard the term of a target eye pressures. Now, in some units, this will be explicitly stated, and it will be in your record or your clinical letter. But in other units, it may be the clinician just has this in their mind. And the target eye pressure is defined as the maximum pressure. So it's fine if the pressure is lower than the target eye pressure, but not if it's above it, which is likely to be low enough to ensure the individual keeps the amount of vision they need for a good quality of life for as long as they need it. So coming back again to the definition. It varies between individuals and also at times between the two eyes of an individual, and it depends on a number of factors. And these are just some example of those factors. So how high the eye pressures have been in the past. So if your pressures in the past have been very high, then just getting the pressure down to a roughly normal level may be enough. But if you've never had high eye pressures, then you may well wish to get the pressure much lower. How severe the glaucoma damage is, and that really just reflects there's just less visual function to play with there, and therefore you would want to get the pressure lower. Similarly, as we discussed before, the older you are, then you have less time where that glaucoma could get worse and have a big impact on your vision. And then the type of glaucoma, some glaucomas are more aggressive than others, and that is taken into account when we are setting the target pressures. One thing about target pressures is really what we're trying to do is predict the future. So we're trying to say, well, if the pressure is this level, then that person's glaucoma won't get worse or will only get worse very slowly. And therefore it is a bit of an educated guess. And it must be balanced against the side effects and the inconvenience of treatment. So what that means is if I set all of my patients to have a very low target pressure and we achieve that, then it's likely that for most of them, their glaucoma wouldn't get bad enough to affect their vision. But on the other hand, lots of them would be on a lot of treatment that they don't need, or potentially undergo procedures such as surgery that they didn't need. So you must balance the two. And another issue which sometimes I think is not well understood is that target pressures are not set in stone and they can go up and down. Here's just some examples. So let's say an eye has a target pressure of 16. And someone comes to clinic and the pressure is 16, so they're on target. However, the visual field is worse, so it tells us the glaucoma is getting worse. So ideally, we should be bringing the target down there and increasing the treatment. But this must be balanced against the side effects. On the other hand, if the same person comes to clinic and their eye pressure is 18, so above target, so normally then we would think, well, should we be increasing the treatment? However, let's say there's no evidence that glaucoma has got worse in the last 5 years. So it may be reasonable in that situation to increase the target pressure rather than give the person extra treatment. Now, it doesn't hold in all situations that, but you can see that what we should be doing there is thinking, does this person need this extra treatment? Which of course often comes with it extra inconvenience and potentially side effects. So how do we decide if the glaucoma damage is getting worse? So as I said, two things we're looking at: the peripheral vision, also known as the field test, and the optic nerve. And with the optic nerve, we generally would look at it clinically on the slit lamp. We would sometimes take a photograph and sometimes take an OCT scan. So in this optic nerve here, there is an area here which shows quite a bit of glaucoma damage. This is a screen which shows all of those things. So there's the optic nerve. This is the OCT scan. And so the optic nerve, there's some damage at the bottom here. On the OCT scan, that's also showing up. It's also showing up in some of the measures here. And then in the peripheral vision test, there's some damage here to the peripheral vision. remember that it's the way that our eyes work. So we're seeing here at the bottom and the bottom of the nerve, the field loss is at the top. And that's just because the way our vision works, things are inverted and then the brain just flips it around again for us. This is some drawings of the optic nerve. So the optic nerve, also known as the optic disc, just to the shape of it, is essentially a hole in the back of the eye, and through it passes the nerves, which pass from the eye to the brain, which is how we see, and also the blood vessels, which pass from inside the skull into the eye and take blood to and remove blood from the eye. And this here is like a perfectly healthy nerve. So when we say, it can be a little confusing, we say the optic nerve, but the optic nerve actually consists of, on average, about 1 million or so individual nerve fibers in each eye. And as the nerves leave, they hug the side of the hole, essentially. So you have this bit in the middle, which doesn't have nerve fibers, and that's known as the cup. And therefore, this term, which you may have heard, cupping, refers to the cup getting bigger. So as the nerve fibers are being lost in glaucoma, the space in the middle without the nerves gets bigger and bigger and bigger. And you can also see, compared to here, because the blood vessels tend to rest on the nerves, as we're losing nerve fibers, the blood vessels are also moving. So this is a very, very nice drawings. The problem with it clinically is that not everybody has nerves like this to begin with. And a lot of the people who are sent to glaucoma clinic because their optometrist is worried that they have glaucoma have nerves somewhere like the C or D. And the issue is there that we don't know, well, if we knew their nerve did look like that a few years previous, we could be sure they have glaucoma, but some people do in fact always have nerves that look like this. So it's just this thing of biological variability, which can make it difficult. And this is where optic nerve photographs are useful, because it provides a record of what it looks like. We have been doing these in hospital setting for many years, but now many optometrists also do them, and that is a very useful tool. So this is one optic nerve here, and this is a year later. So just with the cursor here, I'm just pointing out at the top here, we have a blood vessel coming along. And if we come over here, the blood vessel is going upwards. And what's happened is we've lost the nerve fibers here, so the blood vessels become diverted. And generally, when we look at these, we look at them side by side in order to pick up these slight changes. The OCT, many of you will have had these, and in fact, increasing number of optometrists do these tests now as well. Now, you get a lot of information from these. It's essentially scanning the nerve in the area, scanning the optic disc in the area around the optic disc, and it produces really a wealth of information, arguably a little bit too much information at times, and it's presented in a manner. This is one particular machine, but most of them have something similar, and it's a bit color coded compared to what we consider a normal eye. So it's a normal database where they've tested lots of people who don't have glaucoma, and they're comparing people with glaucoma with it. And you get a lot of sort of green meaning normal and red meaning abnormal. It is not an absolute test, because still similar to the previous slide, you do sometimes get people where everything is red, but actually that's just the way their nerves have always been. So at the end of the consultation, the clinician may say several things to you. It's important to understand what they mean. Like all areas of medicine, we tend to have our own language, which we always assume everybody else understands. But so if the clinician says everything looks good or stable, well, that's pretty straightforward. It's good news. Glaucoma is progressing. So somebody sort of pointed this out to me quite recently, that is something we use to say that glaucoma is getting worse. Whereas in most areas of life, if something is progressing, normally it's getting better. So that can be confusing. But when we say glaucoma is progressing, generally that's not good news. If we say we need to increase your treatment, then usually that means either your pressure is too high, or the test suggests the glaucoma damage is getting worse, and therefore we feel ideally the pressure should be lower. If you're told we need to repeat the test, then normally that's because there's some uncertainty over whether it's getting worse or not. And I would say to you, at the end of the consultation, if you're not really sure what you're being told, it's reasonable to ask for a simple language explanation. Now, this issue of the test may be getting worse and it not being clear leads us on to this. So it is, I think, important to understand to some extent that there's a lot of uncertainty over the tests. So this is really the idea. By monitoring the visual field test over time, we should be able to pick up that it's getting worse in the peripheral vision and therefore change treatment before that gets a lot worse, before it affects the central vision. But variability is a problem. So this is a real life visual field test from the same person. So, and the top left is 1 year, this is a year later. Then we come down here a year later, and this is a year later. And you can see here, bearing in mind the black bits are the bits that we don't see. This is the normal blind spot on the left. So you can see it looks a lot worse there, but then it's got better again, and it's got worse again. And this is not uncommon. And that is partly the nature of the test. And it's also partly a reflection of the fact, and those of you who have done this test will know this, it's not only testing your peripheral vision, but to some extent, it's also testing your concentration, your reaction time, so you press the button quickly, and also your ability to keep your head still in the machine. And that is not easy. This is another example. We encourage the technicians who do the test to feed back to us. And you can hear here, this test looks a bit worrisome. The technician's written that the person was falling asleep during the test. And those of you who have done it, I'm sure will sympathise with that. So this is an example of some tests from 2 years apart. And again, a lot of information. If you stick to this one here, this is the blind spot. There's some vague changes here, nothing major, and it looks worse 2 years later. So how do we know if that is real or if it is just variability? Well, the most obvious thing would be we could repeat the test and see if the results are consistent. The technology also helps us a little bit as well. This is an example from the Humphrey machine, which is probably the most commonly used one. There are some other ones. And so at the top, we have the two tests from years ago. So that's the baseline and then the most recent one. And it also, on this chart here, gives us some ups and downs, and it's giving us a line here, which is sort of the line of best fit. So really, this is telling us that although things are a bit up and down, there does seem to be a decline there. And so even in people where the peripheral vision test is variable, actually, if you do enough of them, often you can get a feeling for the pattern and whether things are getting worse or not. So sometimes it's worth sticking with them. Now, you would think that the OCT scan would be less of an issue because it doesn't really require such a degree of concentration and reaction time. But all of these tests do have some variability in them, and this is the same person about a year apart. Again, a lot of information, but the thing to pick up on is some of the areas before, which were yellow or grey, are now green, some which were yellow or red. So, and this is a reflection of all tests. If you do enough of these measurements, there's going to be some variability there, and it can get a bit confusing. Again, the technology can be useful. So this here is a different machine, but it's scanned from 1 year over a period of 4 or 5 years, and it's providing us a photograph of the nerve so we can check where it's got worse, and also a scan, and it gives us this nice table here where every set of dots is a measurement, and then when we get here, it's extrapolating the line out to say, well, what's going to happen in the future? And again, there's a bit of variability here, but overall it looks pretty reassuring. And so again, with this test, from one visit to the next is perhaps not too important, but what is the pattern over time? So just a summary of that. The tests are not perfect. The visual fields often vary, and the optic nerve scans can be similar, and we do get some help from the technology. But over many years, the pattern often becomes clear, and also it's something which is reassuring that if if the test is getting worse enough that it may threaten your vision before the next visit, this is usually clear. So a big change, a very big change, would really highlight to the staff to look very carefully and either repeat the test very soon or be sure from the other examination that actually things are not getting as worse as that, or getting as bad as that. So moving on. What does the clinician need from you when you attend clinic? Well, the most obvious thing, are you taking the drops and how often do you miss them? So, you know, not many people might take every single drop. It is important to be honest here, and I think that's really because if you're not honest and it looks as though your glaucoma is getting worse because you're not managing the drops, then the most likely thing that will happen is you'll just be given more drops, and of course you're even less likely to use those. So it is important to talk through. And, you know, if you're not taking them, why not? And we try, I'm not saying everyone's successful, but we try not to take the attitude of telling people off for not taking the drops. It's, I think, very important to explore with people why they're not managing them. It's important for us to know, seems pretty obvious, you know, any problems with the drops, any problems with the vision, any problems with your eyes at all. And one issue I think which is worth highlighting is this issue of sort of eye dryness, eye irritation, or sort of intermittent blurring, all of which comes generally from eye surface disease. Now, eye surface disease is very common as we get older, and it's even more common in people who are on glaucoma drops, and it's even more common in people who are on a lot of glaucoma drops. So almost everyone who comes to clinic has a degree of this, and I think it's important to get it across to the staff how much it's troubling you. So if it's something that really doesn't bother you much, just something you notice every few days or a couple of times a day, then generally we wouldn't take any major action on that. We may suggest some slight change to the treatment or artificial tears. But if this is something that's really making your life a misery, then I think, you know, it's important to get that across to the staff that actually this is having a big impact on you. And, you know, is there anything they can do about it? Any worries you have about your glaucoma or your vision, this is the time really to bring it up. And you know, anything else that's really bothering you about your eyes, of course, because we're not that interested in what you might think about Brexit. But moving on, these are the different types of clinician-patient relationships. So the top one, paternalistic, is really the old type of relationship that doctors had with their patients. So you went to see the doctor, he or she told you, this is what we're finding, this is what we're going to do, and you nodded your head and you did it, and your input into it was pretty minimal. The second one, informed medical decision-making, is really where the doctor gives you the information and you make the decision what you want to do. And there are certain areas where that can be useful, but generally speaking, certainly in glaucoma, that is not that helpful. And then the bottom one, shared decision making, which is really what we should all be aiming for now, is where the clinician gives you the information and also gives you their recommendations. But it's like a two-way street, and you know what your values and your preferences and your opinions feed into this, and it's a little bit of a toing and froing until you come to a shared agreement on what is the best way forward. And this is just another way of saying the same thing. So we're really combining the knowledge of the doctor or the practitioner who's an expert in glaucoma with the knowledge of the patient who really is an expert on themselves to come to the right decision. So let me give you an example, and you know, this is a very, very common clinical scenario that I would see, you know, at least once a week, often more so. So we have showed you a few optic nerve photographs now, and so here's one here. Just look at this blood vessel again, and here it's gone up. So we've lost nerve fibres there, and that's reflected in the peripheral vision test getting worse. And that's happened over 5 years. The damage to the other eye is less severe, and the pressure is pretty good in the right eye, but a bit high in the left eye. And the person's already taking these combination drops, so timolol, tanaprost, so combination drops, but just once a day drops. So what do we do next? more drops, and that would perhaps be the most common recommendation in this situation, is that the person has extra drops. Now, that would generally mean they would continue with the drops that they're taking, plus have some extra drops twice a day. And so you're jumping from 1 drop a day to 3 drops a day. However, what we don't know from that previous slide is anything else about the lady. So she can't instill her drops, and her daughter visits once a day on her way home from work to do this. So it sounds like they're managing that. However, if you increase the drops to 3 times a day, is she really going to be able to do that? She doesn't drive, neither does her husband, and they live in a rural area. So that can be an issue on a few fronts, but particularly about coming to hospital. So if we're suggesting a procedure which would require a lot of visits, that may not be the best thing for her. She's pretty terrified of going blind because her father did. She doesn't like medicines. She will take them, but she'd prefer not to have them if she could avoid it. And also at present, she's having chemotherapy for cancer treatment. So, all of these things feed into this. And the simple clinical scenario on the previous page, we weren't getting that information. So this is a perfect situation where it'd be best if we knew this information and we talked through with the patient, would she like more drops? Would she like laser? Would she like surgery? Or, would she like no extra treatment and just like to accept that actually one of her eyes is getting worse, but the other eye is remaining pretty good. And maybe she would prefer just to be happy with that situation, continue her drops and continue to be monitored. And what about you? So all of these things, can feed into it. And it's, if we don't ask or you don't tell us, then, it's hard for us to take account of this. Now, time constraints, we can't ask of everyone, but it's important that you let us know if there's something which is important to you. We all make assumptions based on age. I know that from my own experience. I still recall the man who's 88 and was worried about his HGV license, which was a surprise to me. And I remember a lady in her 70s who wanted to fit her surgery to fit in with her sort of European international athletics calendar, which again is not something you would expect. So everybody's different, and we know that. Attitude to risk is an interesting one, but it does feed into this. This is the Rockefeller Center in New York. I'm sure all of you have seen that picture before. Something a bit more closer to home. Many of us have spent this year being petrified of COVID, and with good cause. However, from the media, it's hard to get the message coming across. It's hard to see that really. So this is people who catch COVID depending on your age, and you can see for people certainly 50 and under, even if you catch COVID, the risk of death is really pretty low. And in the older age groups, even then, the odds are well in your favour that you're going to get through it. So how does this fit into glaucoma? Well, with eye drops, I found that some people will accept a relatively high risk to their vision rather than take unnecessary medicines. They just don't like medicines, or they feel there are enough medicines. Whereas other people would rather have more treatment than sit at home worrying about their vision all the time. And that can certainly feed into treatment decisions. On a surgery, when it comes to surgery or laser, the surgeons are essentially recommending surgery, and we should only do that when the risks of not having surgery, so from the glaucoma damage getting worse, are higher than the risks of having surgery. And by that we mean the risks of complications or side effects from the surgery. However, the two things are not that easy to compare, and the reason for that is that if you have an operation, then you are generally putting yourself at immediate risk of those risks, immediate risk of the complications and side effects, whereas the risk from not having surgery are usually long term. Now, that's not always the case if the pressure is very high or the glaucoma is very advanced, but generally speaking, that's the situation. And that's a situation where it is good to have the individuals' input and how they feel about risk. And as I say, you know, I'm not suggesting you need to be making all decisions here. We're here to guide you, but I think your view is important. Coming back to uncertainty and risk, it is rarely possible to give you an exact personalised risk. We generally base our advice on research studies, personal experience of patients and operations, and your knowledge of you, and that's why it is important to get involved and make sure we know what we need to. Now, this is something we hear a lot about in medicine now, this idea of personalised medicine. And the theory here is there will soon be so much information on all of us. So all of our whole genome will be there. Every test we ever had will be on a computer somewhere. Every medicine we've had and how we reacted to it and how well it worked. And then artificial intelligence will work out what's best for the individual. So I guess time will tell, but I'm not too convinced. I suspect my job is safe for now. So coming to the end of the consultation now, I think it is important to say if you're not sure of the outcome of it, you know, how's it going, how's the test, certainly ask here. It's a good time to ask any other questions that you have. Usually after you have left, although sometimes when you're there, the clinician will do a letter which summarises the visit's findings. Traditionally, that goes to the GP or the optometrist. Personally, and there's a proportion of clinicians do this, I prefer to write to the patient and also copy in the GP and the optometrist, just really on the basis the letters about them, so it's nice for them to get it. I think either way, you can ask for a copy. Many hospitals now send copies by default. I think I would say to you that if there's a big decision to be made, such as surgery, if you're sure you want to go ahead, then fine. If you're not sure, then it is reasonable to ask for time to think about it. You can ask for a letter summarising what the clinician advises and what the issues are. And if that's the situation, make sure you know who you can contact if you have any further questions. After the visit, if you get the letter and there's something in it you don't understand and you'd like to know, or there's something you forgot to ask and you're not going to go back for another 6 months or a year, you can give us a call. One good effect of COVID is that I think eye departments generally now are much better at phone advice. Previously, we just didn't really have time, or people didn't have time set aside to answer phone queries. And over COVID, trying to prevent people unnecessarily coming to hospital, we have become much better at that and give it more of a priority. So most eye departments are better at that now. I'm not suggesting you'll be able to get through first time every time, but you know, if you persevere, hopefully you will get an answer to your question. Practical tips, and it'd be interesting if anyone else has anything else from their own experience. Be honest about how often you miss the eye drops. Any big questions you have beforehand, write them down. If you don't understand what you've been told, ask. As I discussed, get involved in decisions and don't feel pressurised into big decisions. And really that's because in glaucoma only rarely is the treatment urgent. And you know, if I see someone I'm not sure and I feel that they don't have the luxury of a few weeks to think about it, then I will tell them that. That is unusual in glaucoma. I think it's important to remember that the eye clinic staff want to help you. I've never met anyone who works in an eye clinic who didn't want to help people. But I know that sometimes it may not seem like that. And if it doesn't, I think it's just worth remembering that some people, including people who work in eye clinics, are better communicators than others. And some of us are better than others at dealing with the time pressures. So the person who might be very pleasant at 9:15, if it's the morning clinic's stretching on to nearly 2 o'clock and they haven't had their lunch, may not be so pleasant. And you know, I think that's human nature. But even in that situation, you know, I still think you should ask questions. There's still a level of care which you are certainly entitled to. And talking questions, that's all I've got to say. So I'm happy to take any questions.
Thank you, Mike, for a very interesting and informative talk. And I hope that people who are listening will be far more confident at their next clinic visit. If you've got any questions, please ask them. Please use your Q&A button and ask the questions. I've had a couple of email questions, which I'll start off. Mike, this is from Kathy. I realize that consultants face tight time constraints, so would you be prepared to consider appointing a dedicated nurse to provide support and answer questions directly after the consultation?
Yeah, so yeah, I mean, it's a good idea. I guess like a lot of these things, it just sort of depends on the local department and what staff and what resources they have available. In Exeter, we have a lot of nurse practitioners and other glaucoma practitioners, not nurses. And generally speaking, the way the clinic works is they would see the patient first, and then the consultant would see them afterwards. So in that situation, it is there's the opportunity there not only to ask the consultant questions, but also to ask the staff. But it's certainly a good idea.
I've got a question here from David, and he says, how does the diabetic eye screening program fit in with the glaucoma unit?
Well, I mean, I can only speak locally. Generally, it doesn't tend to. It's a different service. Usually it's run out with the hospital, although sometimes the hospitals are involved, but we usually wouldn't get any feedback from them. So usually it's set. So a common thing I'm asked is regarding the photographs. So, we take photographs in glaucoma clinic, and do we have the photographs from the diabetic test of a few years ago? And generally speaking, we don't, and it can be tricky to get a hold of those.
Thank you. And I've got a question from Mike, which is quite involved. I have some questions relating to data as a number of measurements taken when in clinic. We are encouraged to record visual acuity, VA, and IOP. Why? If we don't understand them, then what use do we make of them? Do you want to answer that now? And I'll carry on with or shall I finish the rest of the questions?
Well, I can answer that one first.
Okay.
So I think the question is asking why should the person they write down their vision and their pressures? Yeah, well, I mean, it's a difficult question. I mean, I think it's useful for people to know what their eye pressures are. I guess it's trying to encourage a little bit of ownership of your glaucoma, as we discussed before. But it certainly has its limitations.
And also, why not record CD ratio, as this seems to be a marker of peripheral nerve damage?
Yeah, so we do sometimes record that. So what CD ratio means, cup to dish ratio. If I just show you that picture I was showing you before, if we go back again, and I'll explain why that can be an issue. So if we look here at these diagrams here, so it's relatively easy here to work out what the cup to dish ratio is. So what size is the cup in relation to the whole disc? Probably it's 0.2 there, probably it's about 0.4 there, and here it's more than 0.9. However, if we go to one of these photographs here, it is not always clear because it isn't a clear cutoff. Often it's a sloping edge between the cup and the rest of the disc, and therefore, and we know from studies that if you take a disc like this and you ask 50 glaucoma specialists and ophthalmologists what's the cup to dish ratio, you will get some variability in the answer. And we also know, most of us from practice, that you may, if even amongst the same individual, if you leave it for time, there is a bit of variance in recording it. So it's quite a subjective measurement rather than an objective measurement such as the photograph.
Thanks. Now, to Mike's understanding, VA is less likely to be affected by glaucoma until end stage, and IOP seems to reflect the ongoing management of the pressure, neither of which plots decaying peripheral eyesight.
Yes. So, well, firstly, sticking with the VA, so visual acuity, so when you read the chart, how well you're doing, you're right to say that that's not a good measure of whether glaucoma is getting worse or not. We record that really because we do that really in all eye clinics, and glaucoma patients, as well as the glaucoma, do develop other eye problems, cataract, macular degeneration, and so on. And certainly we feel we want to provide a service for that as well. So if somebody's vision acuity is getting worse, then we want to look and say, well, is it the glaucoma? Or if it's not the glaucoma, what is it? And can we help with it? Or do they need some other treatment? For instance, things such as cataract surgery and so on. The second part of the question was about
to reflect the ongoing management of the pressure, neither of which plots decaying peripheral eyesight.
Yeah. So yes. So the pressure. Yeah. So the pressure is. In my talk there, I separated the two issues: the pressure and the evidence of the glaucoma getting worse. It comes back really to that. Although the pressure itself is not necessarily important, still the only proven treatment we have for glaucoma is to reduce the eye pressure, and therefore the treatment is still aimed at that. So it is not the be all and end all, the pressure, and hopefully that came across in my talk there.
Lovely, thanks, Mike. I've got a question from Facebook here, and it says technician-led clinics remove the patient interface with the clinicians, i.e. go in for tests and clinician subsequently remotely reviews the results. Patients then receive letter with outcome recommendations. How can patients get involved with their care, as this seems a step back from shared decision making?
Yeah, and I mean, I guess all I would say, I would agree with that, as do many glaucoma clinicians, that and from your point of view, it can be difficult sometimes to make judgments based only on results and photographs and so on, rather than having the person in front of you. I guess the truth is, it's a pragmatic decision that I think in an ideal world we'd have more glaucoma clinicians and everybody would be seen in person with the opportunity to talk it through. I guess all I would say is that if it's even though the technician often would not be able to answer some of the questions you have, it is reasonable to raise some of the questions and ask that it's passed on to the clinician to answer. And again, if you have any questions from it, you still should have the ability to call and ask questions based on your, whatever the letter said, if you don't understand it, or it's suggesting a treatment that you're a bit worried about, or you feel is perhaps not the best thing for you. But it is a difficult area, and I would agree with what the point the question is making.
Thanks, Mike. I've got a question here from Jeanette, which may not apply to Exeter, but why don't the outpatients give newly diagnosed patients information about Glaucoma UK and about driving?
Yeah, well, I guess maybe you're better placed to answer that, Errol. I guess, I think maybe they just, I guess I would, I think ideally would. I mean, what advice do you have, Errol, for people who are attending units that are not too involved with Glaucoma UK?
Well, we obviously you've got a very good patient group down in Exeter, and I'm sure that when I speak with the nurses and the ones that organise the meetings, they're quite clear about telling their patients about Glaucoma UK and about the driving side of it. So yeah, it varies, I think, from hospital to hospital, and I think that it may not be a fair question, but it's possibly a relevant question in relation to communication, which is what this is all about today. Yeah. Now, I've got a question here from Catherine, how hopeful are you that treatment to regenerate the optic nerve is something that will be used soon for glaucoma patients. It's a University of Cambridge research.
Yeah, it's a hard question for me to answer. It's not really my field. I mean, I guess I'm hopeful because that would be a great thing. But how close that is to being clinically available, yeah, I'm not the right person to answer that question, I'm afraid.
Okay, Mike.
Yeah.
And we'll have one last question. We've had an awful lot of questions, which is wonderful from our point of view. And those that aren't answered tonight or asked tonight and answered, we will get you answers. You can give us a ring on our helpline. We'll be delighted to answer them for you. There's one last one from Vicky. I had an appointment in May. Tests were done, but I didn't see the consultant. I was told I'd get a letter with a further appointment time. I've heard nothing further though. Do I assume everything was okay with the tests? I would prefer to know either way.
Yeah, again, I guess it depends on the, if that's their practice locally. I mean, I guess all I would say to you is I think that's a very reasonable situation for you to, to try and contact the department, either phone if you can get through and you feel comfortable talking on the phone, or alternatively write to them and ask them, what's the outcome of those tests. And yeah, I mean, it's, doesn't sound ideal. There may be good reasons for it, but I think you're very justified there in chasing that up.
Wonderful. Well, thank you very much, Mike, for your talk and for answering these questions. Some of them have been quite tricky, I think. So thank you very much for listening and for filling in the polls. And I hope, as I've said, that you'll complete the Survey Monkey after the webinar is over. Our next webinar will be on January the 13th at 7 p.m. with Mr. David Lunt, consultant ophthalmologist at South Tees Hospital NHS Foundation Trust. At the end of the webinar, as I've said, the Survey Monkey will come up. Please fill it in. Thank you all for attending. I hope you all have a very good Christmas and hopefully by the end of next year, COVID-free. Thank you very much.